to let people arrive. So welcome everyone. We're just waiting a minute or two to let people arrive. If I can ask you to all mute yourself and keep your cameras off during the presentation, that will help just bandwidth for colleagues. We will be using the chat box, so if you've got any questions, you can pop them in the chat box. We'll also be using Mentimeter through the program, and if I can ask a member of the team to just pop the Mentimeter instructions in the chat as well, so that while we're just waiting for the last couple of people to join us, people can get their Menti set up. Great, so we'll just give it a minute or two more to see if colleagues will be joining us. And for those who have just joined us, there's information in the chat box about how to access the Menti. Don't know, team, if we can allow people to move forward through the Menti questions without us and remove the restriction. It may not be possible to do in real time, but okay, well, let's get started for today. I'm sure colleagues will join us as we go. For those of you who've not met me before, I'm Dr. Justin Varney. I'm the Director of Public Health at Birmingham City Council, and I'll be leading today's webinar. We are recording the webinar, and it will be published alongside the community profile report and the infographics on the council website. Sorry, so if we can move on to a bit of housekeeping. As it's all virtual, I don't need to tell you where the emergency exits are, but if I can ask you all to please stay muted during the webinar. Turn off any of your firewalls will help you more than us, but it does sometimes cause problems with Teams. But do turn off your cameras as well, because again, that will help bandwidth for others. You can use the chat function to ask any questions as we go through or raise hands. We will be using the Menti through today's workshop webinar, and there are some questions in there as well. So I often find it quite helpful to have the Menti on my phone rather than on my laptop and be flipping between screens. And there are instructions in the chat box on how to get onto the onto the Menti. Sadly today, unfortunately, Councillor Khan can't join us, and we've been having some technical problems with her video. So there is a recorded video that we will be publishing alongside the recording of the webinar today, where she shares some of her reflections on this community profile. I know she would have liked to have been us. The video was kind of plan B, and she has been as many of the profile launches as she could. I know from the conversations with her, this is a profile that she feels quite passionate about and really important because of what we're doing to go beyond that kind of label of South Asian and really to unpack some of the differences between our Indian community, our Pakistani community and our Bangladeshi community, and recognise that they're not all one homogenous lump of, not everyone's the same, and there are some quite important differences and inequalities between the different groups. And Councillor Khan is absolutely committed to supporting these community profiles and making sure that not just in the council we maximise the use, but also with our partners across the NHS, in the private sector and the voluntary community sector across Birmingham, that we're taking these documents and making them mean something with our communities and helping them to support action. So if I move on to the Menti, for those of you who've not used Mentimeter before, it's a platform which allows you to interact with us. So we'll ask some questions. There's an ability to ask us questions through it as well. You can either take your phone and get it close to the screen and take a picture of that QR box, and that will take you through to the website, or you can go to www.menti.com and type in 19702386 as the code. And once you're in, you should get to a screen that looks something like this, if I can get the blur to work right on my camera, and it'll say Indian Community Health Profile Launch, and then you know you're in the right place. At any point during the presentation, if you click on the send of the comment, you can put comments in there as well. We won't be answering the comments on the Menti live, but if there are things that you want to flag that you don't want to put in the chat because it's recorded and visible to other people, you can use that as well. So let's move into the presentation, talk a bit about the community health profiles, where they come from and how they fit. So public health in local government has to produce 2 evidence-based reports, and this is part of our statutory responsibilities in public health. The first is the Joint Strategic Needs Assessment. That's a snapshot of the health and well-being of the citizens of Birmingham and the factors underpinning it. And that's a really quite high level kind of picture of what's going on. The new JSNA, the refreshed JSNA, will be coming out towards Christmas as part of the City Observatory platform, which we launched at the end of November. And it draws together data from across the council, the public sector, as well as from things like the census. But it is quite high level. In general, the JSNA doesn't allow us to dive deep into specific communities. The second thing we have to produce under the law is an annual Director of Public Health report. That's an independent report which is written by me and the team, and it's where I choose to shine a light on a specific topic. So in 2019, before COVID, we wrote a report on adults with multiple and complex needs. 2020, we wrote a report on COVID called The Year I Stopped Dancing. Last year, we focused on green space and the environment around us. And this year, we're focusing on the role of digital and how digital affects our lives both positively and negatively. So they're the 2 things we have to do. Then we choose as a public health department in Birmingham to go a bit further than that. So we do this in 3 ways. The first is deep dive. So these are like mini needs assessments. They take about a year to 18 months to do. They look at the published evidence, but they also commission focus groups, and they delve into a specific topic or issue. So for example, we've published one on the veterans community. We've also published one on end-of-life care. So they can be topic or they could be community focused. And they're generally linked to commissioning decisions that we need to make or strategic decisions. So they tend to be tied to that kind of thing. The second thing that we do, which is large pieces of work and take a long time, is topic-based commissions. And this is where we're trying a very different methodology. So we're still looking at the evidence from published research and data, but we're working specifically with community members to kind of go, so what? What does this mean? What's its impact? And how do we change it? And we've got 2 commissions that we've been developing this methodology with. The first is the Poverty Truth Commission, and at the moment they're currently focusing on housing and poverty as a core issue. And the second is Black Year, the Birmingham Lewisham African and Caribbean Health Inequalities Review, and that's just starting its 3rd year and moving from the exploration phase into the implementation phase. So they're the 2 like major pieces programs, and we tend to do a small number of those because they're very time consuming. They take both in terms of resource, but also they take a long time to get to the so what. The third model we use is the community health profiles, and this is a new model that we've developed in Birmingham. It's based on a desktop analysis, so we look at what's published, what's available through the internet, through academic journals, and it's very much based on the data and evidence, and it creates a snapshot of the inequalities affecting a specific community. And if we move on, I'll talk a little bit about kind of the way we structure the community health profiles, which is focusing on connecting to our strategy to become a bolder, healthier city. So they help us understand the gaps, the health inequalities affecting different communities. They focus on a specific community of identity, interest, or experience. They look at where we have evidence of difference both within Birmingham, between Birmingham and national. Some cases we can only find evidence that's national. In some cases, it's only international evidence. We publish the profiles on the council's website, and we aim to refresh them about every 5 to 8 years. And the reason we wait quite a long time before refreshing them is that a lot of the data comes from the census, and the census only happens every 10 years, and they only produce some of the ethnicity data, for example, every 3 years. So there's no point kind of saying we'll refresh it every year, because the picture won't have changed from that kind of data. And then the other thing that we look at is research data, and research takes several years before you really start to see changes in the research database and collection of papers that are published. So about every 5 to 8 years means that we know that there's likely to have been a big shift in the research picture, but also we're likely to have new data at a population level from some of the surveys. So in terms of what we've done so far and the projects and the pieces of work we have in place, so I've talked a bit about the 2 commissions. In terms of the deep dives, the veterans and end of life deep dives have been published. Learning disabilities is on track to be published later this year, and dual diagnosis, so that's people with mental health issues and with substance misuse problems, is due shortly as well, followed by mobility and sensory impairment. So they're in train, but they'll be probably towards the end of the calendar year and the end of the financial year. Then there's a whole group of community health profiles that we've published, and we were lucky because of the Commonwealth Games, we were able to draw in additional resource to really boost those and get some additional ones done through working with partners. And the Indian profile we're presenting today is part of that suite of ones that we've just published. The community health profiles, as I said, aim to give us a bit of a snapshot of the evidence and the gaps between the Indian community and other communities. We've structured them so they map onto the health and wellbeing strategy for Birmingham. And following the publication of the community profile, we then go out to market through the Find It in Birmingham tender portal to commission a community partner to work with us and the local Indian community in Birmingham to say, okay, looking at this, so what needs to change? How can we change things? There is, as part of that contract, some pump prime money for community-led solutions, but it gives a year of focus to really look with the community of how do we respond to this and what do we want to prioritize and work on as a community to change and start to make progress to try and address these gaps. What we also are doing alongside is working within the council and with our partners to help the public sector understand the information that's in them so we can get better at commissioning and providing services for these communities by better understanding their needs. And one of the things that I'm really proud of that we're doing with these community profiles is we are going beyond that kind of shorthand of BAME. It is not good enough in a global city like Birmingham to just say, well, there's white British people and then there's everyone else. We need to really get a bit deeper into this and understand it a bit more. And these community profiles are part of that journey to better understand some of the diversity in our communities. So if we move forward in the slides, it will show you the themes that we have in the Health and Wellbeing Board strategy, and that's how the report is structured. And I'm going to talk a little bit about how we did it in terms of the methodology, but then move on to share some of the findings from some of those key themes and what we've achieved. But if we touch briefly on kind of the how we did it, for those of you who are on the line are interested in the kind of the techie bit, I suppose. So we did it following a standard methodology for what's called a literature review. So it's a standardized way in which you search for data and evidence. And we did that also using kind of standard portals, standard databases where you find this academic research. So long gone are the days where we used to go down to a library and pull an academic journal off the shelf and find it and photocopy it. We can now do it all digitally and find that. Through the report, you'll see that we've used different comparators. And one of the things that I think is really interesting about the community health profile reports and speaks to that point that I was channeling Councillor Khan for, is that we've been able, where we have data, to separate out and provide clarity or comparisons not between our Indian, Bangladeshi and Pakistani communities, as well as with the white British and other white populations and the general population of the UK. And we think this is one of the first times this has actually been done in this way, but it does draw out some differences. And I think that's really important because too often we just go, all South Asians experience this. And actually what these community profiles show is there are some important differences between our Bangladeshi, Indian and Pakistani communities. So moving on, should of course acknowledge there are limitations. So we are reliant on the 2011 census because the 2021 census data isn't out yet. We have to recognise, for example, that some of the language that people use in research is limited. We're limited by what people collected, so whether they asked about ethnicity, also about the language that they use. So some people won't necessarily identify with Indian as their ethnic identity. And one of the things I think we've seen through the last few years is that actually how we describe our ethnicity is much more about a free text box than it is about ticking a checklist, because people people describe their ethnicity in very different ways, and our recognition that there is much more variation in ethnicity than simply looking at as who you hold a passport to or which country you were born in. So moving on to talk about how we share the profiles. As I've said, we produced this written report that has a lot more detail in it. So if there are things in today's presentation that you kind of go, wow, that kind of interests me, I want to know more, please go and have a look at the profile. They're quite long documents, but there's a short infographic version, and there's also a slide set that we've used in today's presentation. We produce a YouTube video as well, which pulls out some of the highlights, and we are working towards translating the community profiles into at least one language. Now, we can't produce them into all of the languages used in India, but we are working towards producing in at least one other language to increase accessibility as well. So after all of that, let's get into the bit that you probably came to hear, which is what does the profile say, and what does it really tell us about our Indian community? So first of all, the profile talks about the size of our Indian community, both in terms of the UK, but also in the context of Birmingham. And from the 2011 census, the data suggests there are just over 64,500 people from India living in Birmingham. There are many languages spoken in the Indian population, and Birmingham is about second largest population as a percentage, and Harrow in terms of across the UK. Of course, keep in mind Birmingham is much larger than Leicester, so we will have more people, but as an overall percentage of the whole population, it will be slightly smaller. One of the things that is interesting, I think, that pulls out through the report is when you look at when do people come to the UK, and about a third of the Indian population came before 1980, but two-thirds didn't. Two-thirds have come much more recently. And what we also see is that this population is younger than the national average and more younger than some of the other populations in Birmingham, particularly our white British population. Moving on, when we talk about the inequalities that come out through the report, and it's important to say, of course, these reports are based on what we can find in the published evidence. So there'll be lots of things where you may, if you're from the Indian community, may say, well, what about this? What about that? This is my lived experience. Or as a service provider, you may say, well, we see a lot of this condition or that condition. One of the challenges we have is actually how little evidence base there is that drills into different ethnic groups and tries to understand these differences. And as I said earlier, too often what happens is we have white British people and then everyone else, and therefore we're really unable from a lot of research to be able to see what is the Indian picture compared to, say, the Kenyan picture or the Italian picture, just white British and everyone else, and that's just not good enough. So we hope that part of the work of these community health profiles is that they will prompt researchers, that they will prompt organisations like the council, like the local ICS, the NHS system, to be better at analysing its data by ethnicity and to look deeper. and to start to report some of this data in a public way around some of the differences, because if more agencies were doing it, we would be able to produce better profiles with more information. But some of the headlines from the profile. So from the research, there's more overcrowded housing. In our Indian communities, there are barriers to accessing particularly mental health services. There's lower consumption of fruit and vegetables, which is a really interesting one, because I think many people would assume that the Indian community actually eat a lot more fruit and vegetables than some of the white community, for example. There are low rates of physical activity, particularly in women, and there's greater prevalence of diseases like diabetes. And interestingly, we're starting to see a rise in dementia conditions as well. And that's quite an interesting when we think about that third of the population that arrived before 1980 who are now getting older and starting to develop dementia. And if we're starting to see increased rates of dementia in our Indian population compared to, say, our white British population, what's driving that? And that will be linked to cardiovascular disease, diet, high blood pressure, other conditions like that. So we're going to pull out some of the things from some of the different themes in the report, some of the sections. So there's a section on maternal health, pregnancy, and that highlights particularly the risk of maternal mortality being higher for mothers who were born in India. One of the things I should say is in the pregnancy data, you often see it described as mothers born in India rather than Indian women. And that's because in maternity data, it asks about the country of birth of the mother, not the mother's ethnicity. So it's to do with the way that the data is collected and the question that's asked. We still see high rates of stillbirth and low birth weight babies. So babies that are born at a lower birth weight are more at risk of having problems, both as a baby, but also as they grow. So all of these say to me, looking at them, you kind of go, actually, there are some real issues around supporting mothers who were born in India and making sure that their pregnancy goes safely for them and for their baby. And that links across to some of the work that we're already doing with local communities around our infant mortality programme and trying to reduce the number of children that die before their first birthday. So moving on to children, some of the data that we have available, we can see that there is a similar prevalence of obesity in children aged 10 and 11 to white British. Which in some senses is good, although I'd like everyone to be a little bit lighter, including myself. We all need to work on this, but it's one of the areas where those assumptions that all South Asian children are carrying more excess weight is just not quite true when you start to drill down to some of the differences. We do see a proportion of children from Indian communities living in low-income households, so child poverty being an issue. But what's interesting, and I think a really good piece, is about the evidence that shows that Indian children only account for a very small proportion of children in care looked after children in England. And that's quite different from some of the other ethnic communities. Now, because of the nature of the reports, we're often looking for gaps. So we're looking for the negatives more than we're looking for the positives. But it is quite important we do celebrate some of the positives when we find them like this, which I think is good news and reflects the work of the community to support children and families. So moving on to mental health and well-being. We see lower rates of detention under the Mental Health Act. So that's people who are what we call sectioned, retained, for treatment and care. We also have some of the lowest rates, we found some of the lowest rates of use of services for people with learning disabilities and autism. And this was actually the lowest rate of all South Asian groups. And on one hand, you may go, well, that's great, because that suggests that there's lower levels of mental health and learning disabilities and autism within the Indian community. I haven't seen any evidence to suggest that's true or false. The other question would be, is this because the Indian community don't feel those services support them and therefore aren't accessing them, and are trying to support family members with mental health issues or learning disability or autism at home without accessing the services because they don't feel that they're culturally appropriate, culturally supported? So it's definitely an area that our mental health provider network should be looking at and thinking about. Because, as I say, I've not seen any evidence to suggest that mental health rates or rates of learning disability or autism are lower in the Indian community. This just suggests that that community is not accessing services in the same way. What's interesting when we look at substance misuse is that there is positive findings in terms of people not drinking alcohol and not using substance misuse drugs in that context. But there's also low levels of smoking. It's important, however, just to say these are lower than the average. They're not non-existent. And it's really important we do talk about substance misuse and alcohol addiction and smoking with our Indian community, because although it's lower, it's not zero. So there's still work to do in terms of supporting people who have addictions in the Indian community. But these are better than many of the other figures in some of the other community profiles. Moving on to talk a bit about food, I talked a bit about dementia, for example, and some forms of dementia being related to coronary heart disease and high blood pressure. That directly links to diet, not just to obesity, but also to salt intake. And that's one of the things that I think is quite interesting, is although what we see is lower rates of obesity in our Indian population than some of our other ethnic communities. And I would just highlight, particularly in the second bullet point on this, that difference between Indian women who've got about 20% of Indian women are carrying excess weight compared to 28% of Pakistani women. So there is a visible difference between Indian and Pakistani women in this case. What we see is about a third meet the 5 a day recommendation. That means you eat 5 portions of fruit or vegetables a day, but that's still far below what the recommendation is, which is all of us should be eating 5 a day. And one of the things that I think is worth flagging is this finding around salt and the use of salt. And over 90% of Indian men and women were actively adding salt in cooking. And we know that there's a very, very strong link between how much salt you use in cooking and in eating every day and blood pressure. And that's one of the big reasons to reduce the amount of salt that you take in, is because it can really drive up your blood pressure. And that can then lead to things like stroke. It can also impact on your risk of dementia. So there's some really important messages here. It's not all great, but there are some good news stories as well. So it's a bit of a mixed picture. Moving on to physical activity. Over half of Indian men and women are achieving the recommended 150 minutes of physical activity per week, and that's great. But we know that if you can achieve 150 minutes of physical activity every week, and that's moderate activity, it's the kind where you can still have a conversation, but you're a little bit warm, you're a little bit starting to get a little bit sweaty, a little bit puffy, but you can still have a decent conversation. So brisk walk, cycling, bit of a dance, those kind of things. We all need to be doing that because that really reduces the risk of things like diabetes. If you're achieving 150 minutes every week, you will reduce your risk of developing type 2 diabetes by up to 40%. And as we showed in one of the earlier slides, the risk of diabetes in our Indian population is higher. So getting active every day can make a real difference. Where we are able to look at some of the differences, for example, the difference between boys and girls, we are seeing some differences in there as well. And some of these, one of the challenges is, as you start to look at gender, you haven't got enough Indian children in the sample to be able to separate Indian from Bangladeshi from Pakistani. So some cases where we're not able to get the separation, we have had to use that South Asian term. And this is one of those examples where we can see that South Asian girls in general are some of the least active. And that's really worrying because we know that if children are inactive, it's very, very unusual for them to suddenly become active as adults. We've really got to lay that foundation of finding physical activity fun and engaging when you're a child if you're going to keep doing it as an adult. Very hard to get someone excited about being physically active if they were really inactive when they were younger. So moving on to working and learning well. This includes things like housing, and one of the things that's quite interesting is that we found that majority of people who came from India, were born in India in the West Midlands, own a property, and that's much, much higher than the general population. We also see some really positive news around education and the number of Indian pupils progressing into higher education, and also the level of economic activity. So there's quite a lot of good news and good context here in terms of positive findings around the Indian community. Moving on to protect and detect. And this is where we talk about things like health protection. So we're talking both around infectious disease, screening, but also talking a bit about crime and violence and justice. What is worrying is that we see a lower uptake of cancer screening, particularly cervical cancer screening. We also see about a third of Indian men who are diagnosed with prostate cancer. It's late. So there is some quite concerning information in this report around cancer. And we know that the earlier you get your cancer found, the better your outcome. In almost all circumstances, the finding of cancer earlier gives you a better chance of living longer. And that's true whether it's prostate cancer, breast cancer, cervical cancer. So there's clearly a lot of work that we need to do with NHS England colleagues who lead on our cancer screening programs to really encourage more men and women in our Indian community to engage with this life-saving programs, because they do make a difference. And cancer is one of the things that we can treat, and we can help prolong people's lives, and it doesn't have to be a death sentence anymore. But if we don't get there till it's really late, much, much harder to give people a good quality of life and treat the cancer. Tuberculosis is an issue that we still continue to see in the context of the Indian community. Predominantly, it has to be said, in people who were born in India, where tuberculosis is much more common, compared to people who are from the Indian community and born in the UK. But we continue to see across the UK, just under 20% of new cases of tuberculosis are linked to people who were born in India and probably caught TB when they were children before they came across. Domestic violence, I thought, again, this is quite an interesting one where we have been able to do a bit of comparison from the research that's there. And that suggests more domestic violence is reported in the Indian community compared to the Bangladeshi or Pakistani communities. Now, domestic violence is one of those areas where it's quite difficult to kind of interpret the statistics, because on one hand, that could be saying the Indian community are doing much better at engaging people about the support that's available. And so the people in the Indian community experiencing domestic violence feel more comfortable, more able to access help and support to help them get out of that situation of violence than in the Bangladeshi or the Pakistani community. The other is that there is a higher level of domestic violence, but it's very difficult to untangle those two. And in general, the kind of national evidence base would suggest that there isn't a significant difference in the baseline level of domestic violence between different ethnic communities. What is different is how confident those communities feel reaching out for help. What's also interesting from some of the research is that we see slightly higher levels of men reporting being victims of domestic violence than women. And it's important to say, when we talk about domestic violence, it's quite a broad definition of partner violence, but there are some dimensions of this which are slightly different, and the report goes into this in more detail. And it is something that we hope that our community safety partnership colleagues and our criminal justice colleagues will pick up on and respond to. Then the final section I wanted to pull out from the report is talking about aging and dying well. As I've talked about a little bit through the report today, there is quite a lot of evidence around heart disease and increased risk of heart disease, and that ties back to more salt in the diet and people not being active enough, driving that. And that heart disease also links across to dementia, which some dementia is caused or linked to disease of your heart and your blood vessels as well, sometimes called vascular dementia. So amongst our Indian community, heart disease is the leading cause of death. We also see for, particularly for women, and for men, we see a high rate of dementia and Alzheimer's as well. We see high levels of type 2 diabetes. And again, as we talked about during the presentation, both diet and physical activity can make a real difference to your risk of diabetes and type 2 diabetes. And if you have diabetes, being active every day and getting your diet more balanced will make a big difference to whether you develop complications as well. I do want to pull out this final bullet point, the kind of pink bar on the slide there a little bit more, because it speaks to what I was saying around the mental health data. Is there's a lower uptake of palliative care and end-of-life support services in our Indian community, yet the Indian community in Birmingham has one of the highest percentages of people aged over 65. And in some ways that may be a good sign, because it may be that families are managing well at home and feel they don't need the services. But there may also be a side of this that families don't feel those services are culturally appropriate, that they're not going to provide the care and support they want for their loved ones at their end of life. And it's a really important thing that we look at with services across the system, that we are making sure that they are compassionate and appropriate. And it's part of the work that we're doing with between the council, our hospice movement, and our wider end of life care sector to develop Birmingham as a compassionate city. And a key part of that is working with different communities in the city to think about what we can do better with them to develop end of life care and end of life support. So I'm going to touch briefly on the 4 infographics. I'm not going to go through them in detail, but I wanted to show you what they look like and the kind of information that's in them. So the infographics designed to give you a bit of a kind of sense of what's in the report, but the full detail, all the references is in the report as well. So the first one just gives you a sense of the size of the community, how the community is distributed across Birmingham. Moving on through the second page, that pulls out 3 of the strands around food, around mental health and wellness, around getting the best start in life, and around physical activity. And then moving on to page 3, we've got working and learning well, protect and detect, and aging and dying well. So this is, if you haven't got time to read the whole report, or you just want to get a flavor of some of the differences, then the infographics are a really good place to just start and get a sense of some of the differences that are there, but the full report's got much, much greater detail. So in terms of next steps, and before we go into the Menti bit of the session today, we are at the moment out to market on the Find It in Birmingham tender portal for a community partner. So if you're a community organisation that works specifically sorry, with the Indian community in Birmingham, please have a look at that portal. There is funding available to support an organisation to work with us over the next year with the local community to say, here's the profile. Where do you want to start? What do you want to do about it? How can we collaborate with you to change some of these inequalities, to close some of these gaps? And as I said, as part of the contract, there is core funding to pump prime community-led activity to start to make a difference. Unfortunately, we haven't got that funding forever, so it's kind of 12-month program, but we hope that will kickstart and support the communities to use this information and think about how they can use it to advocate and continue to change things, so that when we update this in 5 to 8 years, some of those numbers for Birmingham will have changed. We might see type 2 diabetes numbers coming down, because that's something where we can actually change things quite quickly if we do address inactivity and we start to talk about diet and we get people to access services. We could see some of the survival rates, that life expectancy difference, improving if we get people into more screening and we get cancer screening really working in ways which are culturally appropriate and culturally accessible for Indian men and women. So there are things that we can do that can make a difference. This is not inevitable. And that's part of what this second stage of the community health profiles, the embedding and implementation phase, is all about. But that's probably a lot of me talking. So what I'd like to do is move us now onto the Menti part of the program. And if you have a look, you should go to Menti, you should have a code. And I think through the magic of the digital world, Jordan's going to flip us across to the Menti screen and start moving us through the first set of questions. So the first one, this is just to get you a bit of sense of who's in the room, what's the mood like, and get used to the platform. So what I want you to do is use the slider on the screen to tell us a bit about how do you feel at this point. So having sat through a lot of me talking at you, use that slider and you can move it on the left hand side if you're feeling a bit low and down, and on the right hand side if you're feeling a bit more positive and a little bit more upbeat. And the little person in the corner, I can see how many people are taking part at the moment. So about 8 people have managed to get the Menti working, which is a good start. It's about half of the room. So we'll just give it a minute or two for people to, a couple of seconds for people to get on board with it. Brilliant. Okay, and Jordan, if we can move on to the next question. So the first couple of questions are to help us just get a little bit of information about who's taking part today. And one of the reasons for this is later on we're going to ask you kind of so what and a bit of prioritization. Where would you put your focus having listened to things today? And we want to kind of balance that against who's in the room. So if as we go through, if everyone in the room is under 25 and from the Irish community and you're commenting on the Indian profile, it's not going to work that well. So that's why we're asking this, and it just allows us when we're looking at the results later on to just get a sense of who's in the room. What we're not able to do through Menti is look at the specific results, so we can't separate out who said what. It's the way the software works. It doesn't allow us to do that. So this is, I suppose, anonymized in a sense, but it gives us a sense of who's taking part today. That's brilliant. People are moving faster now, so let's plow on with the next one. So this one, we'd like you to describe your ethnicity. So the reason we're doing this as a please write it rather than a checklist is that one of the things that comes through very loudly from our community and from the work we've been doing with communities over the last couple of years with COVID is that the checklist doesn't really work for everyone. And people will pick which word define. It's much better if we let people describe themselves. And a good example of this came up in our Kenyan profile, where although Kenya is an African country, many of the people who come from Kenya would describe themselves as Indian because of their heritage and the strong cultural connections between India and Kenya, rather than describing themselves as Black African on that kind of traditional checklist. So that's the reason we use this kind of free text approach to capture it. Great. So if we move forward, Jordan, on to the next one, I can see people are adding it in. And similarly, we're not using a free text for religion. To some extent, it's easier to classify and use the code, but it may be something in the future that we do as well. Great. Everyone's getting super fast now on it. So let's keep moving on, Jordan. Brilliant. And then I think this is, oh no, 2 more to go. So do you have a disability? Great. And on to the next one, please, Jordan. And then this is the final one of the demographic ones is the first pass to the postcode where you live. So if that's B1, B32, B26, we just need the first bit, not the full bit. Those aren't going to come streaming up on the screens because this is not a guess the postcode bit and we're keeping that confidential, but I can see everyone's done that quite quickly. So let's move on to the question bit. So first question. Having heard what you've heard today and the presentation, how might you in your organization or in your community share this information with the Indian community or with your partners and colleagues? How do you think you could make a difference? So what are the kind of things you could do? So someone was talking about community meetings that they could take it to. Someone else talking about writing an intranet article or a blog. One of the things that we really want to do is encourage people to go and talk about them, and share the information. So it doesn't necessarily have to be a formal, like, I'm going to organize an event, although it's great. Someone talked about doing that at one of our Hindu temples. But it's also about just share the knowledge, kind of go, have you heard about this? Go and have a look. Print off the infographics if send them in WhatsApp groups. Get the word out, because the profiles are only as good as people using them. We don't write these reports so they just sit on a shelf or a virtual shelf looking pretty. One of the really important bits is making sure people see them and encourage people to talk about them. Did you know? Did you see? Have you seen this? Because it's a great way of getting the word out. So some really, really good information ideas coming through. So do pop them through. Great. And if we move on to the next one, please, John. Brilliant. This one's slightly different, and this is really saying, in terms of what you've heard today and what you do, whatever your kind of job is, just taking kind of a couple of seconds to think about, having heard what you've heard today, what difference might that make in what you do tomorrow? And has it inspired you to think differently, to approach this differently? And this one's often the one where people kind of need a little bit of just thinking. Great. And I think, it's really important to acknowledge that point. Someone said, if you come from the Indian community and you're hearing this, and I was discussing there with someone from the community a couple of weeks ago, two things kind of came out. One is, wow, I kind of knew it, but seeing it in numbers I feel it differently, and we need to acknowledge that. And the two was, there's a lot of quite negative stuff, and that again, how do I feel about that, and how do I respond to that? I'm great that someone got the salt message. Really good one. I'm glad I landed that one with you. But it is important, actually. It's important to acknowledge those of us who come from the communities that these profiles refer to. On one hand, sometimes we can approach them with our kind of professional day job on, but also recognizing that we're part of the community, they speak to us, and and that's important as well. I think someone just said, I don't work in a front facing role. What I would just say is, think about also if you work in a strategic role. One of the things that I think hasn't shocked me, because I kind of expected it, but I'm being really disappointed about, is how little we question the data, how many reports we came across where it is white British, everyone else. The data's there. We're collecting the ethnicity data, for example, in the NHS, but we're just not analysing it. We're not bothering to really look at the data through this prism and cut it a little bit further. And so it's quite important people at a strategic level think about it, as well as people in a front time line. And I think somewhere I can just see at the bottom of the screen before we move on to the next one, that point about how do we influence people, particularly people from older communities, historical ways of communities of cooking and feeding their family. It's a really difficult one. At times, many communities, and I found this in my own family many years ago, give food and love together. So feeding someone, making sure that they're well fed, giving them something that's sweet and indulgent, is a sign of showing love. And I always enjoy it when my Indian friends come to visit and there's half a ton of barfi comes with them, not particularly healthy. And how you have that conversation in a way which is saying, I value that and I value the love, but I don't always need it to come with a cake. I can have the cake like once a month rather than once a week. And how do you have those conversations which kind of say to someone, what I want is the love, I want the connection, I don't necessarily need the salt or the sugar. The other thing is we have got a brilliant platform called Whisk, and cooking is a brilliant intergenerational thing. Many of us have got lovely stories where grandparents or parents taught us their favorite dish. And one of the great things about Whisk is it's got a lot of traditional recipes that we've collected over the last year in the run up to the Commonwealth Games, but they've been tweaked by dietitians and nutritionists to make them that little bit healthier. One of the great bits about Whisk is they've kept the taste. So the software behind it makes sure that the taste and the consistency is there, but the tweak just makes it that little bit healthier. So it dials down the salt, dials down the sugar, but keeps the taste absolutely where it is. So you taste it and you kind of go, it's the same butter chicken that I had last week, without realizing that actually it's a bit healthier. So I'll ask the team to pop in the chat in a minute the link to Whisk, because that's a really good one to have as well. So let's just move on to, I think, almost the final question. This one's that question about prioritization. So we pulled out the kind of top 5 inequalities that we saw and ask you to rank them. So in your opinion, what would you prioritize? And that's not saying that is recognizing they're all important, but the reality is we can't do everything all the time everywhere. So how would you put them in order of priority based on that ranking? And as you rank them, you'll see that the one you've ranked disappears from the list. So it makes it a bit easier. Once you start doing it, you'll see you can go back and change it. So if you make a mistake, go back up and swap them back around again. And one of the things I love when I watch this one going, is it moves around all the time. So we're now about halfway through the number of people, and I'll go, yes, this one's coming out clearly as number 1, and 3 people later it will have flipped back down to be right at the bottom. But it's like real-time voting, a bit like the swing-a-thon during the election. Great. So just minute or two for the last couple of people. But interestingly, that physical activity coming out high, that diabetes coming out high, dementia coming out lower, and that may reflect that people kind of feel dementia, not sure what we can do about it. But actually, if we got the first 2 more under control, that would impact on dementia. So they're all kind of connected to each other as well. Great. And then the final 2 questions are, one is, what would future engagement look like? So when you think about what we presented today, the fact we're going to put it on YouTube, we're translating the profile into another language, we're commissioning a community partner, what else could we do that would make a difference? What else do you think might be helpful? And have you got any other ideas? So someone's saying about talking with influencers, working with celebrities. One of the things I really enjoyed actually recently, going to the exhibition at Birmingham Museum and Art Gallery, and they had this exhibition about the history of cinema. And what I didn't know before I went to the exhibition was this whole history about Indian cinema and Birmingham, and how pivotal Birmingham was to bringing Bollywood to the UK, and all of these Bollywood stars who came to stay with the family that were running the cinema, um, and were like popping out to the shops, and huge Bollywood stars who would come and stay for like the launch of their film in the middle of Birmingham. And actually, I remember during COVID, we had a particular outbreak linked to a visiting Bollywood film crew who I think were in Dudley or Walsall filming. So we have those relationships that it's a great idea to think about how we might build on them. And you are able to add to this as we move on. So if you've got other ideas that come through, do pop them on as well. Brilliant. So then I think, Jordan, if I'm correct, this is the final one of the Menti questions. I always say that, and then suddenly there's another one. Oh no, I know there is one more after this one, but this is the final text one. What would good look like? So having heard what you've heard and the presentation today, if we came back in 5 years, what would good look like? Okay, positive change in some of the top 5, recognition of the difference coming through. The Indian community are receptive to it. Great, so some good clear things there as well. Okay, so we're coming towards the end now, but let's go on to the final one. So having hold of that, having had a chance to influence a little bit and having reflected a bit about what people are taking away, seen some of the comments and other things, how do you feel at the end of today? Brilliant. So it looks like it's moving a little bit up, which is always a good way to end the session today. So the team have put in the chat the contact details of the communities team, which is communities team, or one word, at birmingham.gov.uk. If you want to contact us, if you've got any further comments, once you've read the report, if there are things that you want to ask or explore, then do drop us a line. And as we've also put in the link to the tender portal as well, for the Find It in Birmingham opportunity to work with us on making this real in the community. So thank you for your time today. I hope it's been interesting and you've learned a little bit more about our Indian community in Birmingham and some of the challenges for their health and well-being. And I hope you will take away some of the messages and share this information with the people you work with, the people that you socialize with, and the people that you connect with, because it's through you that we get word about this out and we share this information more with our communities and our partners. So have a great day and thank you very much for your time.